talk for today is current updates in peripheral arterial disease. There was no takers for this topic, so I just took it. So basically peripheral arterial disease, why we are worried about peripheral arterial disease? There are 4 clinical subsets of peripheral arterial disease. Either the patient will be asymptomatic or the patient will be chronic symptomatic. Patient will have a claudication pain while walking and it will get relieved with rest. Or the patient will have a chronic limb-threatening ischemia. That means the patient will have a non-healing ulcer or a gangrene which is secondary to the peripheral arterial disease. Or the patient will have an acute limb ischemia. That means the patient will have an acute limb pain which is secondary to a peripheral arterial occlusion. Acute means less than 14 days. Chronic means greater than 14 days. This is the peripheral arterial disease. So patients can be asymptomatic, patients can be chronically symptomatic, or it could be a chronic limb-threatening ischemia, or it could be an acute limb ischemia. The acute limb ischemia and chronic limb ischemia, the difference is 14 days. So why we are more bothered about peripheral arterial disease? So atherosclerosis is a universal process. So it has been found that patients who have a peripheral arterial disease, 50% of the patients will have a coronary artery disease. 20% of the patients will have a cerebrovascular disease. 10% of the patients will have both coronary and cerebrovascular disease. That's why we are more worried about peripheral arterial disease. Peripheral arterial disease is easy to diagnose. So if you diagnose a peripheral arterial disease, you can pick up the coronary artery disease and cerebrovascular disease also. That's why this peripheral arterial disease is more important. So asymptomatic, 20 to 60% of the patients don't complain that they have a pain. Even if they complain, we don't recognize. We say it is secondary to polyarthritis or osteoarthritis and treat them symptomatically. So for every patient who have a typical claudication pain, it has been found that 2 to 5 cases of asymptomatic peripheral arterial disease are present. There are significant percentage patients will report symptoms in an objective walk test. When you ask them to walk in a treadmill for 5 minutes and do an Ankle-Brachial Index, almost 50% of the patients will be positive for a peripheral arterial disease. So if the patient is asymptomatic, does it matter? You have diagnosed that the patient has a peripheral arterial disease, but the patient is asymptomatic, but it is associated with an increased MACE events, major adverse cardiac events and mortality. Hence, it is important to diagnose an asymptomatic peripheral arterial disease also. So if it's a chronic symptomatic, so this is the typical claudication is present in 80% of the patients with proven peripheral arterial disease. So usually while walking, patient will have symptoms and it resolves after 10 minutes of rest. So they can have a significant functional impairment. This chronic limb-threatening ischemia and acute limb-threatening ischemia, these patients will have a ulcer or a gangrene. So these patients are associated with a higher mortality, higher MACE events. The 1-year mortality is around 35% and 1-year amputation risk is 30%. The incidence of chronic limb-threatening ischemia is 11 to 20%. The acute limb-threatening ischemia is 1.7% and acute limb-threatening ischemia has a mortality of 15 to 20%. So whenever you diagnose a chronic limb-threatening ischemia or acute limb-threatening ischemia, then it is an emergency. So how do you diagnose? It's very easy to diagnose a peripheral arterial disease. History, typical claudication pain either in the calf or in the thighs or in the buttocks, and the patient will have a typical pain while they walk and relieved with rest. So this is the typical ischemic pain. Sometimes patient can have a non-claudication type of pain also. Patient can have an erectile dysfunction if the peripheral arterial disease is a little above, obstructing the iliac arteries. So if you examine, there will be signs of ischemia such as nail bed changes, asymmetric hair growth, calf muscle atrophy, or a elevated pallor and dependent lumor. This can be seen. Sometimes you can observe a vascular bruit also. This Fontaine and Rutherford has classified it into stages depending upon the symptoms. So they have classified into 4. One is asymptomatic, Second is patient is have a claudication pain, that is patient develops pain while walking and relieved with rest. 3 is a rest pain, ischemic rest pain. 4 is with an ulceration or gangrene. It's very simple. So patients, if there's a 1 is an asymptomatic, 2 is a claudication pain, 3 is a rest pain, and 4 is a gangrene. So how do we diagnose? We diagnose by means of ankle-brachial index. So ankle-brachial index is nothing but the ratio of the systolic pressure of the ankle with the systolic pressure of the brachial. You get a value, and depending upon that value, we classified whether it's a mild, moderate, severe, or a limb-threatening ischemia. What are the other hemodynamic tests which are available? Is an exercise-induced ankle-brachial index, or you can measure a segmental pressure measurements which can localize the lesion. This is a ankle-brachial index. Normal value is usually 1 to 1.3. So if it is less than 0.4, then the patient is having a severe peripheral arterial disease, and if the value is 0.4 to 0.9, then it's a mild to moderate peripheral arterial disease. So usually the blood pressure is high in the ankle when compared to the brachial. So when the blood pressure is low in the ankle, then that means the blood flow is not going normally to the ankle. So this is the main interpretation of the ankle-brachial index. So sometimes in an elderly individual or in a patient with a chronic renal failure, they will have a non-compressible peripheral arteries. The peripheral arteries will be thickened, so it is non-compressible. In that group of patients, it's very difficult to diagnose by using an ankle-brachial index. In that patients, we have to go for an exercise ankle-brachial index, or there is some other test which you have to follow them. So patients, what are the other physiological tests which are available is, we have a pulse volume recordings and Doppler waveforms which will give an idea in the chronic asymptomatic peripheral arterial disease. There is something known as a transcutaneous oxygen pressure which is measured in the toes, and you have a skin perfusion pressure which can be measured in the toes. This will give an idea whether we have to amputate or not. So if the transcutaneous pressure is less than 30, then the patient will mostly go for an amputation. Similarly, the skin perfusion pressure is less than 40, then the patient will go for an amputation. So this is how an exercise ankle-brachial index is done. You make the patient exercise, tie the BP apparatus, connect it to certain machines, and you find out the BP, and it can unmask the limb ischemia when the ABI is normal. This is how a segmental pressure measurements is done. You tie at very different levels and find out at which point there is a drop in BP. The drop in BP will give you that part of the vessel is occluded. Normal pressures increase as one moves further down the leg, and this test is inaccurate in calcified arterial walls. So to summarize ankle-brachial index, it has a specificity of 80 to 99%, asymptomatic abnormal ABI associated with poor cardiovascular morbidity and mortality. Falsely elevated ankle-brachial index is seen with CKD patients. Exercise ABI at 5 minutes is more sensitive. Segmental pressures will give to localize the PAD, and the perfusion pressure and everything if less than 40 suggests poor wound healing. What are the other imaging modalities available? We have a simple duplex ultrasound, or we can go for a CT angiography or a MR angiography or a catheter angiography. So these are the imagings which are available, and which to choose. This MR angiography and CT angiography is only indicated when you are planning for a revascularization. If you are not planning for a revascularization and if you are planning to treat him medically, then the duplex ultrasound is more than enough. So MR angiography will usually delineate the lesions, contrast enhanced using gadolinium. So only thing, it cannot visualize the arterial calcification, and in a patient with who we have done stenting or post graft, CT angiography will be better than an MR angiography. So there is something known as a carbon dioxide angiography. Carbon dioxide angiography is nothing but, most of the patients who have a peripheral arterial disease they have multiple comorbid illness, out of which renal failure is a must. Most of the time, if you do a peripheral angiogram, the creatinine will be 3 or 4. So giving dye on that patient will be complex, and so carbon dioxide angiography has come, but it has not given promising results. Carbon dioxide is a contrast agent. In case of renal deficiency, it is used. Carbon dioxide temporarily displaces blood but dissolves in 3 to 5 minutes. But the detail we obtain is poor and there is significant patient discomfort. So it is not routinely used. So as I said, whenever a patient has a peripheral arterial disease, there is a multiple comorbid illness. Older age, diabetes, smoking, chronic kidney disease, depression, microvascular disease. So it is very difficult to treat the patient. So every patient has to be individualized. The risks and benefits has to be weighed before treating. Usually it is found that greater than 75 years, the peripheral arterial incidence is 30 to 40%. So these patients will have frailty, sarcopenia, malnutrition, polypharmacy, mobility impairment. So the revascularization should be weighed against the risks and benefits. What are the options available? So we can give medications to reduce his pain in the leg. We can start him on antiplatelet and antithrombotic treatment. You can have a structured exercise program and you can have a preventive food care to avoid ulcer formation. So these are the mainstays of the treatment. Other than that, we have to control the diabetes, control lipids, hypertension, and smoking cessation is a must. So after one trial has come, this is the Voyager PAD design. So what this trial has done is, in a post-revascularization patients, almost 6,500 patients, they have randomized on rivaroxaban and a placebo. Patient is on aspirin. All patients are on aspirin, and they found out the MACE and MALE events. MALE is nothing but major adverse limb events. So what they have found that there was a significant difference found in rivaroxaban plus aspirin arm when compared to placebo. Rivaroxaban is used in a dosage of 2.5. It's used as a very low dosage, 2.5 milligram BD dosage in the peripheral arterial disease. So it has come in guidelines that rivaroxaban plus aspirin has a role in post-revascularization patients. So what would you do in an asymptomatic peripheral arterial disease? Is it necessary we have to treat? Yes, we have to treat because it is associated with increased MACE events. So a single antiplatelet agent is reasonable to reduce the risk of MACE. While if the patient is a symptomatic peripheral arterial disease, single antiplatelet agent with aspirin or clopidogrel, or you can add rivaroxaban 2.5 milligram BD along with an aspirin in a symptomatic peripheral arterial disease. In a revascularized patient, if it's an endovascular or surgical, antiplatelet therapy is recommended. As I already said, rivaroxaban plus low dose aspirin is recommended. And if you see it's a high risk patient, you can start him on dual antiplatelet therapy and low dose aspirin also. So this is again similar to coronary artery disease. LDL should be less than 70 and the systolic and diastolic BP should be 130/90. Smoking has to be cessed and a multidisciplinary approach has to be followed. So there should be, what is the next symptom is leg symptoms. The silastazole is recommended to increase walking distance and reduce symptoms. So silastazole is is a class 1 recommendation for a patient with a peripheral artery disease who has symptoms. So it has been found that after lower extremity revascularization, there is a 4-fold risk of acute limb ischemia. After acute limb ischemia, outcomes are poor and repeat revascularization are frequently required. So whenever you do a revascularization, it is not the end, it is starting of the circle. It will lead to acute limb ischemia and then you will revascularize and then it will rotate like that. So you should be careful to choose the patients which we have to revascularize. So there is something known as an exercise therapy. Exercise therapy, they have recommending some structured exercise programs. So nothing but you ask the patient to walk till the pain comes, ask the patient to walk with the pain till the maximum intolerable pain and ask the patient to stop, wait for 10 minutes and then again walk. So this is how does this help is, so this exercise therapy actually increase the collaterals, arterial collateralization, this improved endothelial function, increase the muscle metabolism, lipid metabolism and inflammatory suppression. So this is how exercise therapy has to be done in all patients of peripheral arterial disease and it is improved the quality of life. So whom do we revascularize? In patients in asymptomatic peripheral arterial disease, it is reasonable to perform procedures to reconstruct diseased arteries if needed for the safety, feasibility or effectiveness of other procedures. It's a class 2A recommendation if a patient is asymptomatic. So what else in a patient, you initially put them on a, if it is a chronically symptomatic peripheral arterial disease, you put them on a medical therapy. So if there is a risk-benefit assessment has to be done, and if the revascularization is an option, then you have to decide which revascularization has to be done. Suppose it's an iotoiliac disease or a femoropopliteal disease, the first option would be endovascular revascularization, and the 2A recommendation is a surgical revascularization. So if it is a common femoral arterial disease, the first option would be an endarterectomy, and the second would be an endovascular approach. If it's an infrapopliteal disease, then the question of revascularization is unknown. The benefit of revascularization is unknown. So basically we have to put them on a good medical therapy. So this is the same thing. So what conduit we have to use is, it's better to use an autologous vein graft instead of a prosthetic material while you are grafting the vessels. So suppose if it is a chronic limb threatening ischemia, it's usually a patient has an ulcer wound, so it's a multi-speciality care. You need a wound care, you have a selective amputation, you have to pressure offload so that the wound may not increase, revascularization and antiplatelet and antithrombotic therapy. So in patients with chronic limb threatening ischemia, surgical, endovascular or hybrid revascularization techniques are recommended when feasible to minimize tissue loss, heal wounds, relieve pain and preserve a functional limb. So there are a group of patients where we couldn't do anything, revascularization. In that patient, there is some usefulness of prostanoids has been tried, and arterial intermittent pneumatic compression devices have been tried. Venous arterialization has also been tried, but they are not with significant benefits. So there is some classification known as an Wi-Fi classification, which is nothing but wound, ischemia and foot infection. Depending upon the wound size and extent, they have classified it 0, 1, 2, 3, and about ischemia depending upon the ankle-brachial index and the TCPO2, and depending upon the foot infection, whether it's a local infection or a systemic infection, this will give you an idea whether we have to amputate or not. In a chronic limb-threatening ischemia, the amputation should be thought, and if whether it has to be done or not should be, it's a multidisciplinary approach. So whenever amputation is planned, you have to do at the most distal level of amputation so that facilitates the healing and provides maximal functional ability. Then the primary amputation is indicated when life over limb is the prevailing consideration. The threatened limb is due to the cause of patient's instability. A patient-centered approach should be used. Use of therapeutic footwear is recommended. So what about acute limb ischemia? Acute limb ischemia is less than 14 days. Patient presents acutely with a cold, painful, pulseless leg. So when you suspect, you do an arterial and venous Doppler. So how do you grade this acute limb ischemia is 1, 2, 3, 4. 1, 2, 3. So basically what is based on the sensory loss or motor loss, whether there is an arterial or venous pulses are audible or not. In 3, arterial and venous pulses are not audible, there is a sensory loss and motor loss. In a class 3 acute limb ischemia, there is no point in revascularization. We have to amputate the patient. So in a class 1, which all is preserved, you have to do a revascularization. In class 2A and class 2B, where there is sensory loss but motor weakness is preserved, the venous pulses are audible by arterial or lost, in that type of patients, the limb is salvageable and revascularization has to be done. So what do you do in an acute limb ischemia? When a patient, it's common for a cardiac setup to have an acute limb ischemia, either due to embolus or a thrombus. Patient commonly comes with an acute limb ischemia. So first we have to assess whether the thing is viable, you can revascularize or not. So the options which are available are, you have a catheter-directed thrombolysis. So what you keep is, you keep a catheter inside the area where the thrombus is, the most distal part of the catheter with multiple side holes, and through that catheter we inject the thrombolytic agent for 24 hours and see whether the thrombus is dissolving or not. So this is the direct delivery of the drug into the existing thrombus, reduces the thrombolytic drug dosage, lyses clot in both large and small vessels. There is a lower incidence of reperfusion syndrome, there is almost 75 to 95% resolution of thrombus in a catheter-directed thrombolysis. The commonly recommended drug is a recombinant tissue plasminogen activator. Usually they give 4 milligram bolus followed by 1 milligram per hour in the catheter. And it can be either given as a low dose, high dose, pulse dose. Several doses have been tried, but the best option is a low dose thrombolysis in a catheter-directed thrombolysis. So what are the devices which are available? We have some devices, mechanical thrombectomic devices, either using the ultrasound energy or a power pulse injection angiojet, and you have an aspiration thrombectomic devices also. So these are the options available. So you do a catheter-directed thrombolysis. If there is no significant effect, then you can plan for a graft or a graft in that patient, in revascularization in that group of patients. So what are the novel therapies which are available? They are trying on several genes, therapeutic angiogenesis, so that they can develop new blood vessels in the area of cell death, regenerating de novo regenerated cells, and siRNA and complementary DNA angiogenic peptide loaded nanoliposomes are also tried. So take home message, peripheral arterial disease, even if it is asymptomatic, associated with increased MACE events and male events, it has a 4 clinical subset: asymptomatic, symptomatic, and a chronic limb-threatening ischemia and an acute limb-threatening ischemia. Detection is based on history, physical examination, and ankle-brachial index, antiplatelet and anti-thrombotic rivaroxaban plus aspirin has shown to be better benefit. Lipid lowering and hypertension control is must. Structured exercise is a core component. Revascularization improves the quality of life and improves the functional status. Food care is crucial, and multidisciplinary approach has been done for a chronic limb-threatening ischemia. Thank you.
It was an exhaustive talk. I don't know whether they caught all you whatever you said or not. I'll just summarize. முன்னாடியெல்லாம் குழந்தைங்களுக்கு மர்மம் இருக்குது அப்படின்னா எக்கோ பண்ணுறதா இல்லையா டிஸ்கஷன் நடக்கும். ஹூ நீட்ஸ் எக்கோ, ஹூ டஸ் நீட். இப்போ அந்த டிஸ்கஷன்லாம் கிடையாது. மர்மம் இருக்குன்னா சீக்கிரம் ஒரு எக்கோ எடுத்தால் ஆன்சர் தெரிஞ்சிடுது இல்லையா. அது மாதிரி whenever you suspect lower limb occlusive disease, ankle-brachial index right now it's more theoretical. We send for arterial Doppler. We have the answer in hand. Subsequently, when you plan for intervention, he clearly explained about MRI and CT angiogram. Now, he told one very important molecule which you might not have kind of listened, what Dr. Madan already discussed about, rivaroxaban, 2.5 mg twice a day. See, whenever we say cardiovascular disease, it's not MI, it's not CAD alone. Cardiovascular disease includes CAD, stroke and peripheral arterial diseases. Whenever the trials say the cardiovascular outcome, it means all the three. But because peripheral arterial disease generally doesn't cause mortality, it causes more morbidity, they include stroke and MI related death as cardiovascular outcome. So please remember, when I say cardiovascular disease, it's not just heart, it's heart, brain and the lower limb. Because all three are having the same disease, atherosclerosis. That's why he said when he started the talk, he said, if you diagnose peripheral arterial disease, you have to treat with the same aggressiveness as you diagnose a MI, because he's going to develop MI tomorrow. So you can prevent MI tomorrow. So there comes the importance. So he said about the diagnosing peripheral arterial diseases and adding rivaroxaban. So antiplatelets, statins, rivaroxaban, and he mentioned about silastazole. These are the 4 important components of the treatment of peripheral arterial diseases. Of course, subsequently, whether it's acute limb ischemia or chronic revascularization therapy, he described. I practically covered everything whatever I have read in all the books. So, congrats. Thank you.